Hello guys, this is Dr. T and welcome to Clinical Medicine with Dr. T. Yeah, if you have not subscribed, please consider subscribing, tell your friends about it, share, like, comment, and thank you so much for your support. Okay guys, so in this video I want to talk about neonatal jaundice. Very important topic. I know most of us, we are very uncomfortable with kids, and it's even worse with neonates. The only way we can start to be comfortable is if we really study and know what's happening. So neonatal jaundice, very important topic, very important, because a lot can go wrong when a patient who's got jaundice, neonatal jaundice, is mismanaged, and then we are going to talk about that later on. A lot can happen, and when you deal with neonatal jaundice, you need to understand which type are you dealing with. Are you dealing with pathological or are you dealing with physiological? Because it would be very unfortunate to have a neonate who has pathological jaundice and you keep that neonate in the ward under phototherapy, because phototherapy is not the treatment of pathological jaundice. And now, what are the things that you can use to classify whether it's pathological or physiological? Physiological jaundice, you can keep that neonate, and they often do well with phototherapy. But once it's pathological, that patient needs to be referred to a higher center if you are at the clinic or at the base, whatever the case might be. Anyway, so in order for us to understand neonatal jaundice, we need to go back and just talk briefly about red cells and their breakdown. Okay, so as we all know that erythropoiesis, which is production of red cells, it occurs or it takes place in the bone marrow. In the bone marrow, and bone marrow has got special types of cells called the hematopoietic stem cells. Hematopoietic stem cell, or simple stem cells. Stem cells are, I like to call them the confused cells. So it's undifferentiated cells. Undifferentiated cells. So these cells have not decided what they want to do in life. Remember, a hair cell is a differentiated cell, a nail, a skin cell, the epithelial cells, bone cells, cardiac cells, muscle cells. Those are differentiated cells. They have decided that, okay, me, I wanna be a bone cell or an osteocyte. Me, I want to be a cardiomyocyte. Me, I want to be a neuron. So those are differentiated cells, but stem cells are undifferentiated, and because they are undifferentiated, they can become any cell depending on the demand and what hormones are involved at that time and all of that. So hematopoietic stem cells can take two routes. They can take the myeloid root, or become myeloid progenitor cells, or the lymphoid root. The lymphoid root or lymphoid progenitor cells. If they take the myeloid root, they can either become a megakaryocyte, and later become platelets, or they can become erythrocytes. This is what I want us to talk about. And then under the influence of erythropoietin from the kidneys, they become erythrocytes. So these are erythroblast, they become erythrocytes. So this is erythroblast. And these are essentially your red blood cells, which we're going to talk about. And then they can go on and become, take the root of, they become white blood cells, essentially. They can become your basophils, your eosinophils, your neutrophils, your monocytes, your mast cells, and that kind of a thing. And then if they take the lymphoid root, they can become lymphocytes, T cells or B cells, T lymphocytes or B lymphocytes, or even natural killer cells. But this is what I want to talk about. Now, you have this cell that has gone through all of that, and now it's been produced and it's released into the blood circulation. So it's going to stay for 120 days. That's our red cell, which has got hemoglobin at the center, right? So this is our red cell, which has got the hemoglobin at the center. So this red cell is going to stay in the circulation and do its job for 120 days. When it gets 130 days, as it enters the reticuloendothelial system, the macrophages there are going to engulf it and break it down. So broken down into so the hemoglobin part will be broken down into the globin. The globin is the protein part. That globin will be further broken down into amino acids. These amino acids will be taken back, and then they will participate in erythropoiesis again to form hemoglobin once more. And then the heme portion will be an enzyme called heme oxygenase will act upon this. Heme oxygenase will break the heme into ferrous, let me just say into iron, break it into biliverdin, right? And then the iron will be taken back to take part in erythropoiesis once more, so it's not wasted. Then the biliverdin, there's another enzyme called biliverdin reductase. Biliverdin reductase, and that enzyme is gonna convert biliverdin into bilirubin, unconjugated bilirubin. Okay, let's just clear space. Okay, so now what we have is, like we said, we had a red blood cell broken down. So the hemoglobin broken down into the globin, into the heme, and then now we have unconjugated bilirubin. This unconjugated bilirubin is lipophilic, so it cannot be transported, or it cannot circulate by itself in the blood. It needs a carrier protein, and that carrier protein is albumin. So albumin comes in and binds it, and then they form a complex, and then this now complex is transported to the liver. So when it gets to the liver, the hepatocytes they uptake the complex, and then the albumin is released. But then the unconjugated bilirubin there's an enzyme that acts, just cannot remember it now. It acts, and then it acts on that complex and convert that unconjugated bilirubin into conjugated bilirubin, which is water soluble. Conjugated bilirubin. When I remember this enzyme, I'm gonna just put it on the comment section, the name of that enzyme. Okay, I know people, they like to make a lot of fuss about conjugated bilirubin and unconjugated bilirubin. Conjugated bilirubin means that there's a molecule that has been either added or subtracted from this to convert it from unconjugated to conjugated, from unconjugated to conjugated. It's all about water solubility and fat solubility. That's what it's all about. So this conjugated bilirubin can now be released from the intestines from the liver into the intestine. When it's released into the intestines, normal flora act on it and then convert it into urobilinogen, right? And about 5% is reabsorbed, and then it goes back to the liver. That's what they call enterohepatic circulation, from the intestines back into the liver. Then later on, it's gonna come back into the intestines, or some of it is gonna go and form urine, be part of urine. The 90% or 95% that remains in the intestines, it's further acted upon by normal flora, and then stecobilin is formed. Stecobilin. This stecobilin is the one that gives the stools or the feces its brown color. It makes sense that if you don't have this, you get pale stools if you've got obstructive jaundice. But I'm not going to get into that. Okay, so basically this is how red cells are broken down. Now you can see this issue of red cells having a life of 120 days, or the lifespan of 120 days, and then later on they are broken down. That's the normal physiology. It's okay, it's fine. But once you've got red cells that do not make it to 120 days, they are broken down before 120 days, that means there's a problem happening. So we need to know what is happening, right? So let's meet in another video where we're going to be talking now about what happens when you've got neonatal jaundice, what it is and how is it classified, and what are the things that you look at to decide is it pathological or physiological. Thank you.